So hello everyone, good afternoon. I'm really thrilled to introduce the speaker of 14th Enigma-Sleep talk, Professor Chiara Baglioni. Chiara is an old friend of mine, and we work together on few projects, mainly on the sleep and emotion regulation. Chiara obtained her PhD in cognitive psychology, psychophysiology, and personality at University of Rome and Marconi Telematica at the university and also at the University of Freiburg. She's doing kind of like research in this field, and I learned a lot from her during the last years. As you know, the title of the talk is focusing on sleep and emotional processes, and we'll have like 15 minutes to discuss the questions at the end of the talk. Thank you, Chiara, for accepting my invitation and joining us. So the stage is yours. Thank you.
Thank you very much, Masoud, for inviting me today and for the presentation. I'm very happy to be here and to introduce the topic about the relationship between sleep, insomnia, and emotional processes. As you said, we've been working together on this topic, and hopefully we can do lots of work more also in the future. I do not have any conflict of interest linked to this presentation, and I would like to present the structure of the presentation. I would like to start with an introduction about the close relationship between sleep and mental health, a brief historical view of this research area. And after that, I would like to introduce briefly how we define and how we study emotional processes in psychophysiological research, and then move to describe briefly the studies that focus on the relationship between emotional processes in sleep and in insomnia disorder. And at the end, I would like to complete the presentation with a focus on the possible clinical relevance of these study results. And I'm using some pictures taken from a new project we are conducting about the study of sleep and well-being during pregnancy. And if there is time at the end, I can also shortly introduce this project. So starting from the first part of the presentation, it is known since ever that when we present mental problems, we also present sleep problems. So we have written testimonials from ancient Greek physicians who were well aware that people with melancholia complain of difficulties of sleep, especially associated with insomnia difficulties, so difficulties falling asleep, difficulties in maintaining sleep, or waking up too early in the morning. And they already suggested some treatments for the sleep difficulties, as listening to calm music and reading, which is something we might suggest also nowadays. And then they also suggested the use of opium or alcohol, which is something we won't suggest nowadays. And also in the first categorization of mental disorder proposed at the beginning of the last century by Emil Kraepelin, sleep problems were associated with some specific mental disorders. For example, in the first categorization, Kraepelin made a difference between two types of depression: a neurotic depression, considered more psychological and associated specifically with sleep onset problems, and an endogenous depression, which was considered to be more biological driven and specifically associated with early awakenings and or sleep maintenance problems. And this was a bit the first idea of studying sleep in mental health or psychiatric research. The idea was to use sleep research to identify early biological markers of mental disorders and especially depression. And the first study is conducted in the 1960s, 1970s, especially from the Pittsburgh Sleep Laboratory, directed by David Kapler and Charles Reynolds, actually showed very exciting results, because in this group, they compared polysomnographic recordings of patients with depression with healthy controls, and they could observe different profiles, especially patients with depression. If I do that, yeah. So they showed increase time awake during the night, reduce deep sleep during the night, and especially some specific REM sleep patterns, reduce onset to sleep, to REM sleep, longer duration of REM sleep compared to healthy sleeper, and an increased REM density. This research was, however, in some way frustrated by a very important work from Ruth Benka and her group, published in 1992. That was a first meta-analysis which wanted to put together all available literature comparing people with mental disorders with healthy good sleepers for in 1 or 2 nights of polysomnography. And the authors could put together 177 studies for a total of 7,151 participants. Mental disorder which could be studied were mood disorders, especially depression, alcohol abuse, anxiety disorders, borderline personality disorders, dementia, eating disorder, schizophrenia, and insomnia and narcolepsy actually were used more as control categories like other sleep disorders. And they compared, and all this study compared this group of patients with healthy controls in the standard sleep variables. So we have total sleep time, sleep efficiency index, sleep onset latency, slow wave sleep calculated both in minutes and in percentage, REM latency, REM density, and REM duration calculated both in minutes or percentage. And as you can see, the mood disorder category, especially including patients with depression, presented the most altered sleep profile compared also to the other categories of mental disorders. They actually, all the studies together observed that patients with depression and mood disorders in general presented difficulties and alteration in all sleep parameters which were considered. I didn't say how to read this table where there is a minus. That means that the group with mental disorder presented less that parameter compared to healthy controls. So for example, reduced total sleep time in patients with mood disorders compared to healthy controls. Where we see a plus, that means the opposite. So the group with mental disorder presented more this sleep variable compared to healthy controls, so a longer sleep onset latency. And where we see the point, that means no significant results could be evidenced. And when there is nothing, that means no authors couldn't put together the data to summarize the results, so lacking of data. And although the group with mood disorder presented the worst sleep profile compared to all other categories, however, the idea that only one sleep variable could be impaired in one single group and then could be considered as an early biological marker of that disorder was actually destroyed, as even REM latency was found to be shortened also in patients with schizophrenia, for example. The only parameter which was impaired only in mood disorder was an increased REM density compared to healthy controls. But as you can see from the table, for most other mental disorders, the author could actually not summarize the data. There was a lack of data, which made it impossible to say whether this was a specific result for mood disorder or just dependent on the lack of data. The result was that after this study was published, for a long time, no much was done in the study of sleep in mental disorders. Some years ago, together with the group of Freiburg, we wanted to replicate the meta-analysis from Ruth Bank and co-authors by summarizing all the research conducted from 1992 to 2015, and then the study was published in 2016. And to summarize the data in a more in a way that could be more easily interpreted. Actually, that was a suggestion of a reviewer. We divided the sleep variables in three main domains. So the first domain was sleep continuity, which was defined by sleep onset latency, total sleep time, and number of awakenings. The second domain was sleep depth, defined by the length, the duration of the three non-REM stages. And the third domain was a REM pressure domain defined by all REM variables, so REM duration, REM latency, and REM density. And we could collect data from patients with affective disorder compared to healthy controlled sleepers. In this case, we consider data only of the second night of polysomnography in the lab. And for this first group, most studies, about 40 studies, were including patients with measured depressive disorder. Only 3 studies had patients with seasonal affective disorders. Then we had another group of anxiety disorder. Consider this study was published in 2016, and most of the literature that we could observe was based on the DSM-4 categorization of mental disorders. And the anxiety group included patients with panic disorder and patients with post-traumatic stress disorder. Then we had a group of eating disorder patients, only including patients, female patients with anorexia nervosa, a group of externalizing disorder, also only including ADHD patients, and a group with Asperger's syndrome and autistic disorder. As I said, consider that we used the DSM-4 categorization, a group with borderline personality disorder, and a group with schizophrenia, all compared with healthy controlled sleepers on the second night of PSG. And especially for the first domain, so the sleep continuity domain, with the exception of only seasonal affective disorder and ADHD, all other mental disorders showed a similar pattern of a disruption of sleep continuity compared to healthy good sleepers. We did find several impairments for several mental disorders, also for sleep depth and REM pressure domains, but not so systematic and uniform as for sleep continuity. And as you know, sleep continuity disruption is actually the core symptom of insomnia. So we came up with the interpretation based also on new model at that time of the relationship of the role of sleep for mental health, especially the transdiagnostic model of sleep discontinuity for mental disorders, that instead considering specific sleep variables as possible biological markers of specific mental disorders, probably sleep continuity could be interpreted as a transdiagnostic process which is relevant for mental health. And when this is disrupted, then people might be more vulnerable for different, for different mental health disorders. And we have evidence from different meta-analysis of longitudinal studies that insomnia which is mainly a disorder of sleep continuity, is a predictor of depression after 1 year or more, or of mental disorders in general. And a very nice meta-analysis published by Masood and colleagues in 2019 actually studied this phenomenon also in a very specific life phase for the women, which is the peripartum. And this is very interesting because in the 3 specific lifetime, which are different for women and men, which are puberty, menarche, and pregnancy and menopause, we have a very high prevalence of sleep continuity problems. So it's very important to study the association between the role of sleep for mental health, specifically for these sensible periods of life. And all this research together actually point out to change in the classical perspective. So the classical psychiatric perspective has for a long time recognized insomnia as a symptom, as a consequence of another disorder, especially depression or anxiety disorder or another condition in general. And all these results actually pointed out that insomnia is a mental psychophysiological disorders which is independent of another condition, so might be often presented in comorbidity, and actually is a risk factor for many mental disorders, especially depression. So now the new perspective is that the direction can be from both sides. Both people with insomnia might be more vulnerable to depression, anxiety, or mental condition in general, and also the other way around. But literature actually showed that in the majority of the cases, people first develop insomnia, and then after a year or more start to present also another clinical mental health condition. And this is the model that we were speaking before, presented by Ellison Harvey and colleagues in 2011, which is the transdiagnostic theory of sleep and mental disorder, and which consider sleep as a main transdiagnostic process relevant for mental health or psychopathology, especially because sleep process interact to all levels, biological, physiological, behavioral, and psychological, with emotional processes. And the interaction between sleep and emotional processes is what defines the substrate of resilience or vulnerability to for mental health. And I will go further to the next section of this presentation by briefly defining what we observe when we study emotional processes. Taking a definition from Gross and colleagues, we need to be careful to use the correct terms, because in the emotional related literature, there is often an overlapping of terms definition. And in this review by James Gross and colleagues, they actually point out to distinguish what is stress, which is mainly associated to negative affect only. So it's a reaction associated to negative affect only. Mood actually refers to longer, more systematic experience, which might be associated to both positive and negative affect. Impulses, we generally refer to impulses to define biological urges like hunger, thirst, sex, pain. And then emotions. Emotions are short responses associated with both positive and negative emotions. We actually define emotions as responses to internal and external or external relevant stimulation, which is characterized, these responses are characterized by a valence. They could be positive or negative, and a specific strength. And these responses can be manifested in different levels, especially in 3 levels: the physiological level. We might feel the heart rate increasing. Subjective levels, we say I'm angry, I'm happy, and behavioral level. So we might smile if we're happy, or we might cry if we are sad. And these pictures are taken, are taken from a very well-known and widely used graphical pictorial scale, which measure the 2-dimension of balance. So I can answer, how do I feel now, from happy to sad, and arousal, so a very calming affective state, or a very activating affective states. I also like this new version of this scale. This is the SAM scale, self-assessment mannequin scale. And this is a new version using this sort of manga boy or girl, which I find it even nicer to use, as is more similar to a human face. We have 2 main approaches to the definition of emotions, which is the first approach. It was to recognize specific basic emotion, which reflect specific neuronal, body expressive, and feeling motivational pathways. So we know we have a recognition of some basic emotion like joy, anger, sadness, disgust, and surprise. And they follow both in animals and in humans a specific neuronal and body expressive pathway. And then we have the dimensional approach to emotion, which actually focus more on the 2, where the emotion feeling is expressed in the 2 main dimensions of balance and arousal. Actually, these 2 approaches are not controversial. They can go together. Especially, there is a theory of 1985 proposed by Watson and Tellegen, who suggests that the categorical approach to emotion can be studied as a subcategories of dynamical interaction between the 2 dimensions of balance and arousal. And it is very important to mention this model, because it's the model which rational is at the base of a very known and very well used questionnaire in psychological research on emotion, which is the positive and negative affective scale, which is a scale composed by 10 positive affective state and 10 negative affective state. And people have to answer on a 5-point Likert scale how much they feel interested, distressed, or excited. And this scale is often very used to evaluate the trait or state, depending on how the instructions are formulated, differences between individuals in in positive and negative affective states. Another important, other important variables which are studied in emotional research are the changes in the different systems. So emotional reactivity is defined as any change in the subjective, physiological, and behavioral levels which a person show after been exposed to an emotional relevant stimuli. And especially psychophysiological research focus on the physiological reactivity to emotional stimuli, which study the threshold, peak, intensity, and rise time and recovery time of a response to an emotional stimulation. We can use different physiological variables to study these physiological responses. For example, we can use EEG or fMRI studies. Interesting in emotional responses also are studied using facial electromyography. For example, studying the corrugator muscle, which is the muscle we activate for generally associated to negative response, or the zygomatic muscle, which is the muscle we move when we laugh, when we smile. And this is a nice physiological variable because it gives an indication also of the balance of the response and not only on the arousal of the intensity of the response. How do we elicit an emotional response in a laboratory setting? We use validated stimulus. A very known validated stimulus are pictures validated, taken from the International Affective Picture System, which is a large database of pictures validated for the dimension of balance and arousal, or the film clips. There are two film clips database, the one from Philippot, published in 1993, and the one from Gross and Levinson, published in 1995. Pro and contra from both type of stimuli, pictures might elicit more precise and defined emotional responses, but film might elicit a more natural response. So it depends a lot on the question of the research. And generally, this is how a study in a psychophysiological study in a laboratory setting is conducted. The person is exposed to an emotional stimulation, and the physiological variable is measured. We can also combine physiological, subjective, and behavioral measures to have a more general and complete idea of the emotional response presented by the participant. Of course, we can also measure emotion and emotional response in real life. Now, many studies are conducted using the ecological momentary assessment design, which permits to study the variables of interest in ecological settings in real life. So generally, you have a smartphone which has a hub, and it rings at random times of the day, and it asks to answer a few questions. For example, about emotion, it asks, how do you feel right now? If you want to study emotional regulation, are you doing something to regulate your emotion nowadays? This is a picture taken from a study we are conducting together with the University of Padova in Italy to study sleep and eating behaviors in adolescents. And we want to use both diaries, so questions which are already defined for time every morning and every evening before going to bed, and pop-up questions which are more associated to this ecological momentary design, which wants to randomly ask questions to people in to capture the more real life situation. Of course, you can combine the app also with physiological measure, for example, with recordings of electrocardiogram or other physiological measures. A construct in emotional related research which is often very studied is the emotion regulation, which is a process which is considered to be transdiagnostic and relevant for maintenance of mental health. Emotion regulation is defined as the ability to regulate emotion, which reflects variation in how well people adjust emotional responses to meet current situational demands. So we need to, we constantly manipulate our emotional responses to adapt to the current demand. I put these pictures. This is a very small book for young children, which with many pictures explain to children how we can regulate anger. So there is this boy who come back home very upset because the tennis game didn't go well and doesn't want to eat at dinner. And then the father say, okay, now go in your room and come back only when you feel calmed down. And then in the room, he feels like all red in the face, and he throw out a monster, a big red monster, which begins to destroy everything in the room. And until the monster destroys also his favorite game, which is a car. And then the boy starts to say, okay, now stop. And he start to put everything in order in his room. And the monster gets from big to very small, and the boy can close the monster in a box. And in this way, the book explains to the kids that anger can be controlled and regulated. And there is a very famous model in emotional research that we often use in research, which is the process model of emotional regulation proposed by Prof and co-authors, which suggests that we can apply a regulation, a modulation of the emotional response in every moment of the emotion generation process. So when an emotion is generated, generally there is a situation, internal or external simulation, which attracts our attention. We formulate an evaluation of this situation. This is a cognitive model of emotional regulation. And from this appraisal, we have a response on the 3 different levels: physiological, behavioral, and subjective. And in each time of this emotion generation process, we can apply our emotion regulation process. We can select the situation. We cannot go to a party if we think we can be too upset. We can try to change the situation when possible. We can try to move our attention to other stimuli. We can try to re-evaluate the situation, and we can try to modulate the response. And research especially focus on 2 emotion regulation strategies, which is the cognitive reappraisal strategy, which tries to reformulate our interpretation of a situation by seeing things in a more widely perspective, and it's been considered an effective and functional emotion regulation strategies because it is associated with a reduction of the emotional response on the all 3 levels. And the behavioral suppression response is actually considered a maladaptive emotion regulation strategy if used systematically and not dependent on the context, because it's specifically associated with an increase of the physiological response and of the subjective response, although it is still associated with an effective reduction of the behavioral response. So we managed to make a poker face if we want, for example. There are more emotion regulation strategies than not only cognitive reappraisal and problem solving, for example, and behavioral suppression. For example, many psychotherapeutic new generation model focus on the strategies of acceptance, like the mindfulness protocol or the acceptance and commitment psychotherapy protocols. And just a minute on this new model, which I find it very interesting, proposed in 2010 by Kappens and colleagues, which define individual difference in emotional response dependent on 3 main aspects. And home-based difference, so we differ on the home base of our positive and negative emotion and on the arousal of our standard trait feelings. We different on the affect variability. There are some people are more stable, they have a more stable experience of emotion, and some people feel a very high fluctuation of different emotion during the day. And we different on our ability to return our emotion response to basic levels. And together also with Masoud in a recent review that we published in 2023 on Journal of Sleep Research, we actually put together these 2 models of emotional processes, because the difference in which we use emotion regulation strategies might be associated to these 3 levels of differences explained by the DNAF effect model. And now I just did this long introduction on how we define emotional processes, because now I can go pretty quickly in explaining what has been done in sleep and insomnia research. So first of all, when I speak about insomnia like this, Pinnett's because comic, because it underlines how insomnia is a problem of more than only one night. First of all, the first studies specifically studying emotions in sleep or insomnia, sleep quality or insomnia patient, they actually use the PANAS, this scale of 10 positive and 10 negative affective scale in people with good sleep quality or poor sleep quality, or in people or in patients with insomnia compared with healthy sleepers. And the result of this first group of studies actually showed that people with poor sleep quality or patients with insomnia tend to present systematically more intense negative affect states compared to healthy good sleepers. It was a bit more complicated to identify a more stable pattern for positive emotions. Some studies found less intense positive affective states in people with poor sleep quality or insomnia compared to healthy sleepers. And some other studies found actually a protective role of positive emotions for sleep quality. So also those presenting high negative affective states, if they also presented high positive affective states, they still reported a good sleep quality, but this was not a stable result. Another group of study actually studied people in a specific life condition as lonely people, people with externalizing disorder with higher levels of anger, hostility, people living in grief. And they all found that in this situation, people report poor sleep quality and insomnia symptoms. And there was a few studies studying adolescents in romantic love situation, and they actually find a specific pattern of sleep which presented a shorter sleep duration, but actually not a disruption of sleep efficiency and quality. And so the first review have been conducted with Dieter and the group in Freiburg was to underline that the etiological model of insomnia disorder, they spoke a lot about a physiological autonomic hyperarousal and a cognitive hyperarousal, but it was a bit neglected the emotional experience of this hyperactivation, and which could actually be the breach, explaining the breach between the physiological hyperarousal and the cognitive hyperarousal. And the first studies we've been conducted were using the facial electromyography, especially in the two muscles I was speaking before about the corrugator muscle and the zygomatic muscle, and people were exposed to neutral positive and negative picture taken from the YAPS database, and then some specific sleep positive and sleep negative pictures. Sleep negative picture represented were photographs of people in bed at night, very frustrated watching the clock showing 3 o'clock in the morning, and sleep positive picture were picture of people calmly sleeping at night. And what is interesting of these two first studies that we actually could replicate the same results, and we could find that in both studies, patients with insomnia presented a lower level response of the corrugator muscle in response to sleep positive pictures as a sort of craving response for a situation that they actually desire. In Freiburg, we've been conducting an fMRI study. In this case, we use only negative and neutral pictures, and we match the set of pictures for balance. So we had 3 negative picture sets and 1 neutral picture set, and we had 3 moderate arousal picture set and 1 high arousal picture set. And the first result we found an increased amygdala reactivity only in patients with insomnia in response to insomnia-related pictures compared to healthy sleepers. And what was also interesting, we found only in healthy sleepers an increased response to negativity of the pictures, even in 2 sets with similar levels of arousal. And this difference, we couldn't observe this difference in patients with insomnia. Then a last study conducted always in Freiburg was directed to analyze in an ecological momentary assessment design the differences between patients with insomnia and good sleepers in emotion and emotion regulation process. So we could collect data from 97 patients with insomnia and 86 controls. Controls were divided in two groups. One group, one half, could sleep as usual, and the other half was instructed to sleep no more than 5.5 hours per night. So it was in a situation of sleep reduction, partially sleep deprivation. They had a full screening, including telephonic, psychological, and medical screening, and then they were invited for 5 days to use a smartphone and to complete sleep and emotional diaries every morning when they stand up and every evening before going to bed. And then for 4 random times per day to answer to questions about how they felt and if they were doing anything to regulate their emotional response or not. And a summary of the results showed that patients with insomnia compared to good sleeper in both conditions presented increased sleep difficulties and increased emotional difficulties associated with increased negative affective states and more intense negative affective state, less intense positive affective state, and a more systematic use of those considered maladaptive emotion regulation strategies and this behavioral suppression, and a less use of adaptive emotion regulation strategies as cognitive reappraisal or acceptance. Independent from group allocation, higher sleep alteration, defined as longer sleep onset latency or wake after sleep onset, were associated with increased negative affect on the next day, and a higher wake after sleep onset and heart rate variability were associated with an increased daily emotional variability. And only in patients with insomnia, the days in which they reported a higher use of adaptive emotion regulation strategies was actually associated with better sleep. And this is a summary of the review Masoud and I conducted together. I was telling before, summarizing very shortly because I have to come to an end. We could summarize literature which showed that patients with insomnia disorder compared to healthy sleepers present a higher emotional reactivity, both in physiological and in subjective levels, average increased negative balance and intensity of a negative affective states, and alteration of emotion regulation strategies linked with a higher daily and weekly affect variability. So with an experience of more fluctuation on the emotional response compared to healthy sleepers who presented a more stable emotional patterns during the day and the week. And that was the question. We have a new concept now in sleep research, which is the sleep health dimensions. And is sleep continuity the definer of good sleep? So is sleep health dimension, is sleep health defined by essence of good sleep? And is this related with better mental health? I think this is an all-open question. We have in the first review published by BICE in 2014, actually we can see that only 2 dimensions of sleep health are associated with mental health. It would be interesting, in my opinion, to conduct study between sleep and health dimension, emotional processes, and their relationship with mental health to understand if some sleep health dimensions are more fundamental for mental health compared to others. And a very last comment, it is interesting to conduct these studies also in specific groups to understand better gender sleep differences or the lifespan differences. For example, understanding these variables, the relation between sleep, insomnia, and emotional processes in children and adolescents. And that brings me to the very last part of this presentation, in which all these studies brings to 2 main clinical possible application. The first possible application is that early offer of cognitive behavioral therapy for insomnia disorder might be an intervention which is not only effective to treat insomnia, but might also prevent the cascade of negative consequences which are associated to insomnia as depression or other psychopathology. We actually have first studies showing that might be the case, although I think literature should grow on this clinical area of research. And the other question is whether applying early treatment based on the cognitive behavioral therapy of insomnia and emotional regulation training, but this might be effective in treating patients with mental health disorder or preventing mental health disorders. And so just before concluding, as I said, I wanted to shortly introduce the studies we are currently running. We actually would like to evaluate whether an early intervention based on cognitive behavioral therapy for insomnia and emotion regulation training in early pregnancy might actually provide benefits for well-being during pregnancy and reduce the risk for postpartum depression. And we are conducting this study with the University of Bologna, and we are looking forward to have first result. This is a combination study which combines a part on an animal model of the relationship between sleep, emotion, and sleep, stress, and consequence on well-being, on health, and studies evaluating patients or human pregnant women and we want to follow the women until 6 months of postpartum, and this is shortly the session of the intervention, which include specifically a part on how sleep and emotions interacts. And I think I can conclude now so that we can have time for questions.